I do have a conflict of interest, obviously, since I'm a clinical pharmacologist. So this means that if I will talk about treating pain, that I may actually overemphasize the use of drugs. And there's a whole complete field on prevention and non-pharmacological interventions, which actually are also very important to consider if you really want to consider the full pattern of pain treatment or analgesia in neonates. But I will only briefly touch on that, because it's not rocket science. This is a picture that I took when I was in Ghana for a PhD thesis, which was actually on antibiotics. But it's not rocket science. If something hurts in adults, it's likely also the case that it will hurt in newborns. So we have to think how we can treat us. Also, for instance, if you consider the repeated checking of hypoglycemia, hyper or hypoglycemia, perhaps new tools or new equipments may be actually very helping to improve our care without raising actually the invasiveness. When I was preparing this talk, since I live in Belgium, we have two different languages. I thought I will also try to instruct them a little bit on Dutch and French. And so I built this lecture. I think it's 6 or 7 suggestions, actually, I forgot. But the first suggestion is doing nothing is not an option. This is what it stands, but this is the Dutch version. And what I mean with that is that we should not accept pain in neonates. And it's the main message that I want to get across with this part of this suggestion is this is not just an issue on compassion. This is not only from ethical perspective, but actually it's a basic good clinical practice. Because we all know that babies inadequate management of pain in babies will cause later harm. And this has to do to a large extent with, again, developmental neurology, as has already been discussed for several aspects. But you should be aware that if you consider the central nervous system, that sensory receptors are indeed already there. They funnily actually first develop perioral and then subsequently will go from craniocaudal development. At the dorsal horn, you have the interneuron as a connection, but you should be aware that the normal anatomy that you may have learned in adults is not yet there in newborns, for sure not yet in preterm. So, say the different layers of the ventral horn are not so well discriminated. So this means that any reaction will be, or any input into the central nervous system will be handled much more diffuse and much less accurate in a preterm baby. You have the connections thalamocortical with visual sensual, visual cortex and auditory cortex, and also have some biochemical studies who suggest that substance P and enkephalin are already there in quite early life. So this means that actually, if you do the studies, which has also been done, for instance, to a certain extent also in Scandinavian countries, that indeed, if you consider cortical activity related to pain stimulus as an important indicator of indeed the presence of pain, that this is already there from 22-23 weeks onwards. It's even already there in fetal life. And I recently searched for this publication because I wanted to figure out how the hell have they done that. But there used to be a time that you did transfusions in fetuses through the belly into the liver. So in this way, this was another painful model compared to the currently much more commonly umbilical cord access. So what these colleagues did is a quite complex study where they did paired analysis in babies who had to undergo fetuses, who had to undergo different intrauterine transfusions, or an unpaired design, then babies they only had to undergo one intrauterine transfusion. But what actually was nicely to show that indeed beta endorphins, so the reactions to painful, stressful was indeed there, much more pronounced if they went with the needle through to the hepatic vein. They also assessed the arterial pulsatility index and also the cortisol. So actually, even a fetus can already mount pain. Some specific aspects I think are important to realize why we should be specific worried or specific focused in neonates and in preterm neonates is again their neuroanatomy. So if you simply look at what we call receptive fields, you may also know this from, say, your general training. In general, we know that specific receptive fields are located to a specific place in your spinal cord, and this way your pain stimulus or your motor stimulus will either go up or down. But this is not yet fully the case in newborns, and for sure not in preterms. You should be aware that actually there are interconnections over here. So this means that again, that the receptive field does not really exist yet in newborns. So if you, like for instance in the fetal system, if you stick into the belly, that actually the pain signal will go much broader over the central, over the spinal cord compared to an infant or compared to an adult. So because of these interconnecting neurons at the spinal level, you will have a much more diffuse impact on the central nervous system. Does this matter? Well, you cannot always do this type of studies in human newborns, but you can use animal models. And this is just one illustration, actually illustrating that an early insult rewires pain circuits. What they showed over here is an animal model where they used Freud adjuvants. And Freud adjuvants is not a funny thing. It creates something like an arthritis. And if you would do that in being me, an adult rat, if you would do that in this paw, you will have a signal at the level of the spinal cord connected to that, and you will have upgrade or downgrade for given receptors. And then it will go to your brain as a signal. In a preterm model, because rats are by definition born preterm, in a preterm model, this is not so simple. Because if you give this same stimulus at the same place, what you can see over here is actually the composition of the spinal cord. What you could see over here is that this pain signal is much more diffuse all over the spinal cord and even at the contralateral side. So this means again, because the central nervous system is not only all about becoming much more bigger and more complex, it's also about eliminating routes which are no longer needed, that because these interneuron connections at the spinal cord are still there, that actually this pain signal will have impact all over the spinal cord, and similar data have been shown also for the thalamus and the upper limits. What is known in children or in newborns, I think it's still important for those who are relatively new in the field, that in contrast to other human populations, that there are data up to the level of randomized placebo-controlled trials, that if you do not treat pain well in newborn, that he's more likely to die. As I alluded yesterday, the advantage of dying or mortality is that it is quite robust outcome variable. You cannot mess around with it. So what Sunny Anand did in the late 80s of last century was doing a study in a PDA ligation model. For those who are, again, new in the field, there used to be a time that we believed that you should close any PDA, and if you could not close it with drugs, that you simply ask the surgeon to put a clip on that. So at that time, we did it much more common. But what he did in this model was actually do a randomized controlled trial, and half of the babies got opioids, fentanyl, and the other half of the babies only get muscular relaxants. Because at that time, we still believed that opioids may not have been a good option for neonates. And actually, this study was stopped prematurely, sorry for the word, but because the death rate was higher in the control group, and actually in the same group, they also illustrated that infectious wound-related infections, stress response was indeed much more pronounced in the group not exposed to opioids. So in contrast to other human populations, we have randomized controlled evidence that we have to treat this accurate. What has this to do with this other slide, which is now on the program? Well, similar type of data has also been documented for, say, what is, quote, minor surgery. Minor surgery is in general in the mind of those who do it and not to those who have to undergo it. But the model that has been used by Anna Taddeo was a circumcision model. And Anna Taddeo at that time, actually, she really wanted to explore potential gender-related differences in pain expression. And actually, she was wondering, is this related to culture, or is this nature or nurture? Are female babies more sissies, and are male babies more heroes? Something like that, or the other way around. So why does it differ? And what she did actually use a vaccination immunization model, because all these babies have to undergo immunizations at 2, 3, 4 months. And actually what she saw is what quite commonly happens in medicine, is she didn't find the data that she was anticipating, because what she found is that the male did not behave normal. Well, most of you already know that, but I mean the statistical concept. And if she looked at the male patients, she actually could find out two different groups. One group who was crying longer and harder, using cry time and duration of crime and vigorousness or the pain scores related to that. And the funny thing is that when she checked what happened to these children once they were 2 to 4 months old, that's the main message. Actually, that the babies, the boys who underwent circumcision at birth without any analgesia, indeed were expressing more distress 2 to 4 months later. This shows you that these babies still, quote unquote, knew what happened 2 to 4 months ago. Perhaps not in the cognitive way, but at least in the behavioral and the central nervous system type of way. So there are effects, short-term mortality and long-term pain expression. And the funny thing is that subsequently they were able to show that indeed better management of these type of things largely normalized these pain responses. So the circle is closed. Yes, we have to treat neonatal pain not only because we want, but also because we have to. So it's not only a matter of compassion, it's also, or ethics, it's also a matter of good clinical, good nursing care. The second suggestion is in French, and actually it says it's better to prevent than to cure. And this is what I alluded to with non-pharmacological things. Walk around your units, think, see how we do things. I mean, how common does it occur that the baby comes back from an operated theater and say, well, we removed a part of his belly, but he still needs a deep venous catheter, you can do it tomorrow. Well, half an hour ago, he was still asleep. Or, well, we do not like to put urine catheters in it, you're better than that. Say, well, this baby is awake now, we have missed the opportunity. So all these type of silly things, cluster care, discuss with your nurses what you can do, when you can do it, how you should do it, if you have to do it. I mean, this is something that we have to take in mind and is way beyond giving a simple drug. Techniques matter, and there is techniques related to type of surgery for ROP, for instance, but this is one of the papers who actually tried to assess the difference between a simple venipuncture and a heel lancing, and actually nicely showed that if you want to collect blood for Guthrie testing, that venipuncture is much more effective, being defined as the numbers of sticks that you have to give, being defined as the duration of the procedure, and defined as the comfort of the baby. This has been documented in 2 different studies. This is one from this region of the world. There's also a paper in archives who actually confirmed these things. And other aspects also is what I lived through, being not yet so old in neonatal intensive care, at least in my perception. Old is your own age plus 10. What I lived through, there used to be a time that any baby that had to undergo MRI was sedated and ventilated. And there used to be a time that the youngest anesthesiologist came across to do this job, because this was easy. And there used to be a time that they believed that even, for instance, for propofol, that any baby will immediately awake after you stop the propofol. No way. I've seen babies sleeping for 24 hours after propofol intoxication. So we can also avoid drugs by using feed and scan or other type of techniques. That's the second message that I would like to get across. Now we're shifting a little bit more to my pharmacological patterns, obviously, and I would like to focus on paracetamol or acetaminophen, and I would like to stress that the route matters. This is in part infested by the fact that I have to work in the Netherlands now, and they are quite fixed to the use of rectal acetaminophen. And since I'm working there, I'm trying to shift it. I managed to do this in Belgium, but I still failed to do it in the Netherlands. The Netherlands is a much bigger country, but I think they're also much more stubborn. But this is the dosing that in general that we suggest, and it's not about the figures. You already have these slides. What I would like to stress is that rectal administration doses are different compared to oral or IV doses. So what does it matter? It does matter that something like bioavailability of a compound matters if you give given doses to drugs. And to be honest, I was a little bit lazy, but I still, because I respect Brian Anderson highly, I still kept this slide in because similar data are available in preterm and term neonates, but these are data in children. And what happened in these children is they all underwent ENT surgery and they all were treated with 20 milligram per kilogram of acetaminophen, and all individual lines or individual connected plasma observations. And the upper panel was treated with rectal, the lower panel was treated with oral. And actually what you very nicely could see is that there's a difference. And actually if you look at this slide, I like to stress 3 different things. The first one is this differs. The concentration axis following rectal does not go really highly beyond 10 and then goes down, while oral it has a peak concentration and subsequently will decay. The second message hidden to a certain extent, because you have to look a little bit better, is the time axis. If you go for oral, for this dose, you have a reasonable concentration down to 6 hours after administration. If you go for rectal, this only concentration is documented after 3 hours, and then actually we do not know. The most important message is actually the third message. In essence, it means if you go for rectal, you do not know how much you have given. This is a comment related to statistics. On average, the bioavailability is about 50%. So this means you would have, on average, attained the same exposure if you would have given 40 milligram per kilogram rectal compared to 20 oral. But the basic problem is that it is on average. And as you can appreciate, rectal administration, it goes everywhere. Some babies actually never reach any treatment, while others will have a much more effective absorption. And in preterms, actually it has been described that there is even a little bit of difference between boys and girls for rectal administration. It has never been seen for oral. I have explored all my data on IV, we never could squeeze it out. So this is simply a stupid anatomical issue between boys and girls. But this means that actually in real life you have an absorption between 20 and 80%. So you do not know. You can feel very comfortable by rectal administration of the drug, but could be that actually even after repeated dosing in analgesia, you will never have any therapeutic concentration, or you may be the unlucky guy who ends up to toxic concentration after 3 or 4 doses. So rectal administration is difficult to predict. It can be considered for single dose and perhaps even a little bit better for fever compared to pain, because for fever you need a lower threshold to be effective. So in this way, please consider also the route of administration. Having said that, and again, I do have some personal experience with paracetamol IV. That's actually a funny story, I should tell it. I used to be young and promising, and, but as a child, unfortunately, I had a severe arthritis of my hip, so I need to undergo a hip replacement when I was a initiating PhD student, and thought, well, that's okay, let's have my hip replaced, and in the meanwhile I will write my PhD, piece of cake. Well, didn't work out, completely, but the funny thing is the first day that after surgery that my first paper came out, I still remember. The unfortunate part was actually I was treated with local regional anesthesia. It would have been great if I had a knee replacement, but unfortunately it was the hip. So this local regional was not so perfect, and I had to stop NSAIDs because I was bleeding like hell. So the only thing that I had to survive on was IV paracetamol. It works. It was not double blind, but it was effective. And it takes 10 to 15 minutes before it's really effective. And this is also what has been illustrated in babies. What is currently ongoing as a study in Rotterdam, in the PICU, is can you also apply these opioid-sparing concepts to cardiac patients? But what has been proven is that it is indeed a major opioid-sparing effect when you combine opioids, morphine, to paracetamol in non-cardiac neonates and infants. So it's opioid sparing. If you read the paper well, they sell a little bit, their message a little bit quite effective. They say we can reduce opioid exposure with 66%. That's correct for the maintenance dose, because all these babies got a loading dose when they were discharged from the operated theater. So paracetamol is opioid sparing. For minor pain syndromes, we've also been able to show that it is effective, showing the pain scores over time, and indeed with a decay down to 6 hours, which fits in quite well with the data available in children and in adults. What it doesn't work for is procedural pain. And I've just highlighted this for heel stick, but the very same data I have reported for screening of retinopathy of prematurity or for wound care, because there's a general perception that if it is an analgesic, it should work for everything. But one of the messages that I would like to get across is it's all about the traumatic surgical care is a whole different ballgame compared to inflammation type of pain compared to procedural pain. This doesn't work. Actually, it's better than morphine. But if you want to use something which reduces the pain scores, we are still stuck with sucrose or glucose. These are much more effective than drugs or than real drugs. Because for sucrose, you can question whether it is a drug or not. So I simply summarize these data for heel stick, but you can find the same type of data for other type of procedural pains. And I come across a lot of guidelines within given units that they say, well, we'll give that, but actually it makes care providers more comfortable, but it doesn't really comfort the baby. So for paracetamol, I had 3 messages. The first was, yes, it's opioid sparing, also in neonates, as has been repeatedly also documented in children and adults. It's effective for minor pain syndromes, but it doesn't seem to be effective for procedural pain. So if you go up to the more potent analgesics and sedatives, I really would like to go back to the pharmacokinetics. Because as we know, we all use very different type of compounds in a unit, and it's okay. It's better to stick to some drugs and learn the advantages and the disadvantages of them instead of using the drug of the month and then change every month. But still, I would like to get you through some specific comments which are relevant, likely to preterm and neonates, and we sometimes work the other way around. And the first message is please consider a loading dose for both morphine, for both paracetamol, and likely also for some other analgesics. And again, this relates to this slide that I showed you yesterday. It's not only the weight, also the body composition difference. And I also showed you this slide and understood that not everybody was amused yesterday if I said compared babies with jellyfish. It is not my intention, but actually it makes you think about what we do. But to further broaden the scope, actually, if you are lucky and have a very prosperous life, we may end up as a calamaris. So geriatrics is a whole different ball game, and actually they have a different body composition. So in this way, it makes you think about, and the good news is, if you're growing older, it's not about gaining fat, you simply have lost your water. But this means that if you use this type of concept, it's terribly important for pain management tools to consider loading doses. And if you look at babies, children, and adults, the practice of loading doses is much more common in adults, less in children, even never in newborns, while actually, based on the physical conditions, it should have been the other way around. And this is what we suggested for different opioids and for acetaminophen, paracetamol. So please consider loading doses only subsequently followed by maintenance doses. Why does this matter? It's a little bit topical illustrated over here. If you just start with the maintenance dose and you give it repeatedly, like for instance paracetamol or morphine intermittent, you will get there, but it will take time. If you go for a loading dose, you will immediately be there and you will remain there. Why is this important? Because I hope that you have nurses who are committed. And if you don't give a loading dose, what will happen is that if the baby is not comfortable, that this nurse will come and say, well, this baby is not comfortable. And what you will do is, well, let's raise the maintenance dose. And then a few hours later, she still says, well, this child is not comfortable. Let's raise the maintenance dose. And then the day afterwards, your baby is asleep and comatose. And you have to wait another 24 hours before the baby gets rid of his drug. So that's, I hope that some of you recognize this pattern within your unit, because that's the way that you have to handle it. Again, a little bit similar like the antibiotics of yesterday. Shoot hard and keep on target so that you can get rid of this drug as soon as possible. And this we have modeled for acetaminophen. So if you simply go for IV, and this is even higher than what is recommended at SPC, I think that at present the SPC suggests 7.5 milligram per kilogram per time, 3 times a day or 4 times a day. Before the product ever came on the market, we used 40 milligram, 4 times 10 milligram per kilogram per day. But what you could see over here with an additional loading dose of 20 milligram per kilogram. If you don't do that, It's okay, but it will take you 18 hours before you're on target. So this means that if you combine it with other drugs, that may still be okay for the baby. But if you use it as a monocompound, you can actually be much more effective by using a loading dose. In the meanwhile, we have collected quite some data also on safety of tolerance. So I'm not so afraid of this type of drugs. We have not seen any effect mainly related to liver. And just do not try this at home. But if you ever end up with a newborn baby, and really newborn, so the first week of life, and by error you give the famous tenfold dosing in these babies, they will be okay. A baby by accident, because of its immaturity, is protected largely to acetaminophen toxicity, because they don't have yet the enzyme to make the compound which will generate toxicity. You should not aim for that, and if you end up with this type of problems, please stick to the current guidelines, go for the lisomycil and treat the baby as needed, but you can actually say quite comfortable to parents that this will very likely turn out to be okay. It has been repeatedly described. We have summarized all cases recently, and it seems to be that preterm and term babies in the first weeks of life are actually rather tolerant to paracetamol intoxications. So distribution volume matters. The second aspect that matters is obviously clearance. How do babies get rid of this drug? And I only have two examples to illustrate that. And the first one is recently published work from the group of Rotterdam on fentanyl. And actually I learned quite a lot from this drug, or from this study. This is a study which has done in extreme low birth weight infants, so from 24 to 32 weeks onwards. What you can see, this is the postnatal age of these babies. These are the individual clearance estimates, and what you can see is the older the baby at birth, the higher the clearance. That's not rocket science. But secondly, the older the baby in postnatal age, quite high clearance. So again, what you see is an explosion in the first week of postnatal life. So the way that I try to understand these data is that for those of you who use fentanyl and have the impression after 1, 2, 3 days, oh, my baby is becoming tolerant, I have to raise the dose. Well, if you simply look at the data, it may be that the baby is simply eliminating faster and still is the same target. This is perhaps a busy slide for the most of you, but I walk you through. What you could see over here is the same baby, 0.75 kilogram, day 1, day 10, day 20, day 30. And all were treated with 1 milligram per kilogram per hour of fentanyl. What you can see at birth is indeed you have a peak and a quite high concentration, but the very same dose 10 days later, actually this baby has a much higher clearance, and so the exposure will decrease quite significantly. So if you start with 1 microgram per kilogram per hour for fentanyl in your unit, it's quite likely that after 1 or 2 days you will have to raise the dose with at least 50%. And it's not only tolerance, it's simply because this baby is more effective to get rid of this drug. So it may also be an interesting observation. Another aspect what I learned a lot from is propofol. And propofol is a little bit a tricky one, because propofol is fat. You cannot pee fat. So you have to metabolize propofol before you ever can get rid of it. And we, adults, we metabolize propofol by glucuronidation. That's the main route to get rid of this drug. Babies are notorious by being poor in glucuronidation. That's why they develop bilirubinemia. So what we did in our PK studies was simply explore a dose of 3 milligram per kilogram. Do not remember that. This is at that time what the anesthesiologist yelled that was the normal dose. For IV bolus when we did stuff in these babies. And what you can see over here is a theoretical model. All these babies are treated with 3 milligram per kilogram, and subsequently you have a decrease with time in the concentration. And one part of the slide is not rocket science. The smaller the baby, the lower the clearance, so the higher the exposure. So this is the most immature baby, this is the big one. So that you know. But at least as interesting is these two slides where actually these trend lines are up to next to each other. And what they reflect is a term baby at birth. So for instance, the asphyxia baby who has to go to MRI, or the cardiac baby who has to undergo intubation before he goes to the cath lab or whatsoever. And the other one is a 27-weeker of 10 days old. So again, if you ever use propofol within your practices, be aware that also term babies may have much more problems to get rid of this drug because, again, it has to undergo glucuronidation and babies are notoriously weak to do that. We have used this model, this prediction model, in an ED50 study. And you have to be aware on epilepsy, it has been just suggested, we can predict quite well concentrations. That we are good at, but we do not always know how much you have to reach to give a given effect. So this ED50 was really meant to, can we intubate this baby in 50% of the cases? So that's quite low. And it was a study which actually continued with continuous adaptation. So if we were effective in intubation and extubation, this was insured, then it was rated as okay, and we went down to see, can we go lower? And then in the next stratum within the same child, if we failed, we went up again. So this way you can actually try to explore how much you have to give. And in essence, we ended up with 1 to 1.5 milligram per kilogram for effective intubation and subsequent extubation, because that's the tricky thing of insure. And that's another message that I would like to give you. If you consider drugs for intubation, my main question is, why the hell are you intubating for? If it is for an insure, your outcome should be completely different when you compare it to transport teams. Say, well, I want to intubate this child and subsequently have to drive or to fly 2 hours. Then you have another completely different outcome. Then you can still use propofol if you're comfortable to intubate, but you have to give something next. Otherwise, this child will be awake before he's in the incubator. The fifth suggestion is there is a lot of different practices. And this is how it is. You can see trends. Again, these are data for the pediatrics data sets, or morphine and fentanyl. Fentanyl are going up a little bit in popularity. Morphine also quite popular. In ventilated low birth weight infants, still quite a relevant number of patients are exposed to opioids, while actually there are no data to support this standard practice as a standard. So these are other data from Europe and from Canada, again suggesting that there's quite some variability, tenfold variability between 3 and 41% of cases exposed to opioids. So we vary in our practice. To the very best of my assessment, what is available in the current evidence actually does not suggest to use opioids simply because of ventilation. So what is generally done in units is you try to assess discomfort, and the baby is really discomfortable. You can always initiate opioids, and again, if you do so, please consider loading doses. Structure matters, or at least pain management. So a little bit like the care bundles on CLAPSI of yesterday, also care bundles on pain management guidelines may be quite effective. And I felt that this was a nice paper on that, who actually nicely illustrated that if you structure care, you actually significantly reduced in their hands the need for opioids, and also the number of babies needed methadone because of iatrogenic NOS picture. So finally, the main issue on pain management remains its assessment. Let's be honest. What we use is pain behavior, expression in our pain scales. Or even worse, we use physiological parameters like heart rate and this type of stuff. Well, actually what we would like to know is nociception and pain. So we still fail to a certain extent, but things are making progress. Because when you develop pain scales, you can use a lot of different things. For me, a promising observation is the pooled data from, I think, Oxford group of Rebecca Slater, who actually nicely showed that indeed, that if you consider pain expression in newborns, that there is a major impact of gestational age. Whether it's painful or non-painful, it's hard to discriminate. Actually linking to these maturational central nervous system aspects. And in term babies, it's much more easier to discriminate a painful from a non-painful stimulus using the clinical pain expression of the child. And intriguingly, the very same has been shown for EEG monitoring. As you know or may not know, They are working on what they call noxious specific brain activity patterns. And again, what they were able to show is that indeed in immature babies, it's much more difficult to discriminate tactile versus painful stimuli. But in term babies, we are almost there to really recognize a painful compared to non-painful stimulus. Why should we bother about assessment? Because there's also a growing field of developmental toxicology. The analgesics and sedatives are not perfect for the brain because they create also apoptosis and impaired synaptogenesis. The way that Sonny Anand tried to handle this in an animal experimental model was compare surgery or inflammatory pain without analgesia, inflammatory pain with analgesia, and analgesia without pain. And actually, the best outcome was for those who got the treatment when they needed it. Again, the advantages in an animal model that you can structure this quite well. In neonatal care, it's still quite difficult. But anyhow, you should be aware that there's a lot of fuss and a lot of noise ongoing on potential toxicity. And most of these data are generated by animal experimental things, but there's a lot of discussion, is this the right dose? For instance, if you sedate a mouse and it gets hypoglycemia, what will it, to what extent will this affect the brain? But anyhow, there's some epidemiological data like this one, where the incidence of learning disabilities is related to the number of exposures to general anesthesia in the first year of life. But you can see whether you have to undergo one or two anesthesiology, none or one during the first year of life, it doesn't really affect your incidence of learning disability. But if you have to undergo twice or more, it has a significant effect. It still is difficult because this epidemiological data, at least if you have to undergo two anesthesias, it may be that you had a colostoma that has to be repaired, or you have a cardiac issue that has to be undergo different. So it's difficult to disentangle these. But there are some data generated by a colleague anesthesiologist, and these are the most recent data at the years of 5 years as part of the GAS trial. And the GAS trial, actually what they did is randomize boys, mainly because it was inguinal repair, to either general or local regional anesthesia during surgery. So short intervention, and what they were able to show that there were no differences in neurobehavioral outcome, neither at 2 nor at 5 years. The studies are obviously discussed because it's a minor model, and if I understood it well, these colleagues still are trying to make a more sophisticated, more extensive anesthesia model also to prove that this is the way to go ahead. And finally, I'm very much aware that this is likely way too small, but I can read it over here. The similar data are upcoming for paracetamol. There's a lot of data on atopy and paracetamol exposure. There's quite some data also on neurobehavioral issues, ADHD and behavioral issue, autism spectrum problems. There are also issues related to fertility and paracetamol. So there is also over there something. We should not feel comfortable and run away towards paracetamol because we feel that it is okay. It may still also be an issue over there. So I'm done with repeating my suggestions. So wachten is geen optie. So wait and accept for analgesia is for sure not acceptable. It's better to prevent than to treat, but I have not extensively explored on that. For paracetamol, we know that it's opioid sparing. And for minor pain, it's okay, but not for procedural. Learn to enjoy, at least use peak pharmacokinetics. So consider loading dose concept. Consider the fact that babies, while on your unit, will display maturation clearance and may need different doses to attain the same effect. Assessment is still poor, but first steps are making towards more technical assessment of that. And safety and toxicity does remain a relevant issue, even down to acetaminophen or paracetamol. Thank you very much.